Just a reminder with our mission. Everybody is familiar with it by now, and I'm doing your best. And if you believe that we can be the most educated in the nation or in any community, please share your knowledge that you learned today with everybody else you know, or tell them to watch the videos or join us. It doesn't matter how you do it, just find a way of doing it. I thought it'd be a good idea to just go over the first and the second webinars before we go to our current webinar. In the first webinar, we talked about the large team of physicians and nurse practitioners and physician assistants and nurses and surgeons that take care of patients with atrial fibrillation and the multidisciplinary efforts it takes to take care of patients with atrial fibrillation. We also discussed how atrial fibrillation is an electrical issue in the top chambers of the heart. On the left here, you have the top chambers beating together before the bottom chambers. The top chambers we call atria. On the left, the top chambers are fibrillating. And when you lose the electrical synchrony in the top chambers, you lose the effective contraction of the top chambers, and that results in multiple issues, including the symptoms, the heart going too fast, getting weaker. But the most dreaded complication is having a clot forming in the top chamber of the heart, namely in the left top chamber of the heart, and that clot can break off and pumped out of the heart, goes to the brain and causes stroke. And we discussed options to mitigate the risk of stroke in patients with atrial fibrillation by taking the pill, whether warfarin or any of the new pills, anticoagulants, or for those who cannot take anticoagulation, how we can use non-pharmacologic option, namely Watchman device and left atrial appendage clipping. We also agreed that being in sync is much nicer than being out of sync. Sinus is nicer than atrial fibrillation. Now, in webinar 2, we discussed antiarrhythmics. And we started by discussing and defining the difference between paroxysmal atrial fibrillation, where atrial fibrillation episodes in red comes and go by themselves without having to do anything, and usually they limit themselves to less than 1 week in duration. Then going to persistent atrial fibrillation, when each episode would require cardioversion, whether by electrical shock or by medications to terminate, then progresses to permanent atrial fibrillation. And we discussed that electrical shock is simply a shock that gets the heart back in rhythm by exercising an electrical shock with the pads that deliver the shock positioned anteriorly and posteriorly, in this case, where the heart in the field of that shock that's delivered, and that gets us back in rhythm. And we discussed that the earlier you intervene, the more successful the cardioversion is. If we try to cardiovert somebody within the first 2 days of developing atrial fibrillation, we're almost certain we're going to be successful in getting back the sinus rhythm. If we wait more than a year, the chance of that being successful drops significantly to less than 75%. We also discussed the difference between transthoracic echocardiogram that's done at the bedside without need for sedation, and we discussed its limitation, versus transesophageal echocardiogram that requires sedation, anesthesia, probe put down the esophagus, which is the tubes that connects the throat with the stomach, and have a better look at the top chamber of the heart and better evaluation of the presence or absence of a clot inside the heart. We also discussed the 2 main classes of antiarrhythmic medications, class 1 and the class 3, with the different medications, and that class 1 antiarrhythmics is safe when the heart in really good shape with no problem, no weak heart, no thick heart, no prior history of heart attack, and no significant disease. When you have significantly diseased heart or weak heart or heart failure or prior heart attack or significant blockage in the arteries, then class 3 medications would be a reasonable choice. And if you have bad kidneys, out of the class 3 medications, you're left mainly with amiodarone, and we discussed the amiodarone bad side effects. And we ended by saying, no matter what antiarrhythmic medication you use, it's much better than not using that medication, keeping people in rhythm. And then we highlighted, although that antiarrhythmic medications are good in maintaining sinus rhythm, but they are not as good as catheter ablation, which is the focus of our webinar today. Now, last time we promised you to have an email, so it's easy for everybody to register. And this is an easy email to remember, AFib webinar at bhcpns.org. And you, of course, you can call. And I think Patrick told me that there is only one Zoom number now.
Yep, same every time.
Okay. And once again, this is a good opportunity to thank Patrick for everything he does. He makes everything look good, and he does all that behind the scenes. So the catheter ablation talk today, the objectives of it, the main objectives are to learn the principles of catheter ablation, the anatomic targets for atrial fibrillation ablation, and the types of catheter ablation, including radiofrequency catheter ablation and cryo ablation, and of course we'll touch on surgical ablation. We'll learn about the ablation procedure and its complications, and we'll finish with the indication for catheter ablation. Just a reminder, atrial fibrillation is a problem in the top chambers of the heart, and this animation represents atrial fibrillation as an electrical problem with so many electrical circuits going on in the top chamber, making it lose its effective mechanical function or contraction. And this is a representation of atrial fibrillation where you have the two top chambers, the two bottom chambers. Instead of having the sinus node in the right top chamber taking care of making electricity, we have so many electrical circuits in both top chambers. So how are we going to break those electrical circuits is the focus of our webinar today, and the goal of trying to get people back in rhythm. So let's go back to the basics. This is an electrical circuit, and you can see the current flowing. How do you stop that circuit? Well, it's simple. You have a switch, and you turn that switch off, you break that circuit. So if you apply the same principle on the heart muscle, this is basically muscle fibers of the heart muscle itself. And these are the fibers stacked. When you have an electrical current going through the muscle, that's what with those circuits cause the electrical arrhythmia in case of atrial fibrillation. So to interrupt that circuit, you can think, okay, let's cut that muscle fiber. But if you cut it only partially, there's still an area that can allow the electrical circuits to go. And if you cut it even more, no matter how thin the fiber that's left connecting the two sides of that electrical front, you still have leak. So you really have to cut the full thickness of the electrical muscle in order to stop the electrical current from flowing. Of course, that's not a smart idea to do. Unless you do that, then you suture it. What would that give us? A scar. Scar does not conduct electricity. So by cutting the heart muscle, in this case in the top chambers, and suturing it back, you create electrical barrier, a roadblock. You create a scar. Scar does not conduct electricity. And as I told you, we have to do that in order to be full thickness breaking of that electrical current. And that was actually the basis for the first surgical ablation procedure for atrial fibrillation that's called Cox Maze Procedure. Cox, after Dr. James Cox, that first performed this procedure in 1987 at WashU in St. Louis. So let's understand the basis for that Cox Maze procedure and move from there to catheter ablation basis. This is the heart again. The normal electrical pacemaker is located in the top of the right top chamber, the right atrium here. We call that the sinus node. That makes electricity, let's say 60 beats a minute, once every second. And that signal travels to the left top chamber and also travels to the bottom chambers through another electrical connection. We call it the AV node. So if we think and draw this whole thing in a different way, this is the sinus node, this is the AV node, and the two top chambers, Dr. Cox drew it like this. This is the left atrium, left top chamber. This is the right top chamber. And this is how the signal travels from the right to the left and from the top to the bottom. And he came up with these surgical incisions that create barriers to the electrical current to go around and stop those electrical circuits. And he created this in a way such as that electrical signal that starts in the sinus node can still travel to the left top chamber and down to the AV node And because of the shape of those well-done surgical incisions that are not random, and they look like a maze, that's where the maze surgical procedure name came from. And you can imagine opening the chest, opening the heart. On pump surgery, it's extensive surgery. This is the back of the left top chamber. These are the pulmonary veins that bring the blood from the lungs to the left top chamber. And these are the surgical incisions we're talking about that are created. And of course, that surgery has been modified so many times, and you have maze modified 1, 2, 3 different ones with different lines each time to make it easier, less invasive, and more effective. Nonetheless, that is the surgical basis for the first ablation, for atrial fibrillation in the 80s. And since then, everybody has been thinking how to achieve scarring in the top chambers using catheter. Something we can maneuver, small catheter, we can go inside through the vessel into the heart and create that scar. So let's talk about the basics behind catheter ablation so you can understand it. This is the body, this is the heart inside the chest. The radio frequency current is actually an AC current, different frequency than the electrical current. It's like 350 to 500 kilohertz. We put the catheter inside the body, into the heart. We touch the tissue of interest to create the scar. And then the current flows between the tip of the catheter, through the tissue of the heart, through the body tissue, to a patch, a grounding patch on the surface of the body, and that completes the current back to the RF generator. So the point of contact between the tip of the catheter and the tissue of interest, in this case, the heart tissue, as the current flows between the catheter tip and the tissue, at the contact point, there will be resistance to the flow of the electrical current. That resistance creates heat. We call it resistive heating. That heat, once it reaches certain degrees centigrade, greater than 50 degrees centigrade, it damages the tissue in a way that's irreversible. And the tissue next to that gets some of that heat and gets damaged as well. Now remember, we need to create a full thickness damage in order for that lesion to be what we call transmural, meaning full thickness lesion. And this is the best I can find for you, a heat map of an actual catheter tip here in contact with the tissue. And this is a fluid flowing. The hottest point at the contact point with the tip of the catheter, this is the resistive heating area. The neighboring tissue gets some damage. We call it conductive heating. And as you continue to apply that radio frequency current, the depth of the lesion increases until you hope to achieve full thickness lesion. The good thing is the blood flow at the tip of the ablation catheter provides some cooling effect. Otherwise, the tip of the catheter will get so hot, it can cause a thrombus or a clot to form, and that can break off and cause a stroke. And of course, we went through a lot of innovations and inventions to minimize that risk between the first generation and the generation of catheters we use today. So this is another representation. This is the tip of the catheter that we use for ablation, the contact point, the tissue we're trying to ablate by creating a scar, full thickness scar. And you can see here, we're using 20 watts. We use 20 watts for 30 seconds. Bigger tip, more watt creates full thickness lesion. So we can adjust the size of the tip of the catheter, how long we apply the current, and what wattage we use. All these are tools we can use to achieve full thickness. How does the tissue look? What does it look like when we finish with our ablation? This is pig's heart. This is the ablation catheter. In contact with that tissue, we applied the radio frequency current, and we have lesions and full thickness scar. And that's what it looks like. People think, wow, what's going to happen to the function of my heart? What's going to happen to the tissue? What's going to be looking like? It doesn't look like anything else. It simply looks like a smooth, pale lesion. There's no way for the electrical signal to go across this barrier. And there are a lot of circuits that can go around to cause arrhythmia. Once we create this line, you stop those electrical circuits that are dependent on this area here to go around. If we look at the pathology, or if we cut through and look at, through a microscope at lesions we create by ablation, you can see this is the healthy tissue here, the red, and this is the lesion that creates the scar. The same thing here, another lesion creating scar with healthy tissue around it. The point I would like to bring up and highlight here, sometimes our lesions at the surface, you can have clot forming because those surfaces, they could be what we call thrombogenic. They could be easy surfaces to have a clot form on them. And that can explain to you why we keep people on blood thinner after ablation for atrial fibrillation at least 2 months. That's the time we believe it takes to heal those lesions and reduce the risk of stroke. Even if your CHA2DS2-VASc score is 0, after we do the ablation for atrial fibrillation, recommendations and guidelines are to continue with blood thinner for 2 months at least, and recommendations are 2 to 3 months. So that explains why. After that, if your CHA2DS2-VASc score is 0, we can stop anticoagulation after that. If your CHA2DS2-VASc score is 2 for men or 3 or more for women, you need to be on a blood thinner after that, regardless whether you go back in atrial fibrillation or stay in rhythm. These are the current guidelines. Now we understand how to ablate surgically and much easier and less invasive by using the catheter. The question is, where to go? What part of the top chambers we go to achieve those ablation lesions that will stop atrial fibrillation from happening? The basis for our understanding and for defining our targets comes from the original study by Dr. Hasseguier from France, who performed the first ablation targeting atrial fibrillation. He found out, again, let's orient ourselves to this picture. This is the right top chamber, right atrium, left top chamber, left atrium, with the 4 openings of the vessels that bring the blood from the lungs to the left side of the heart. We call them pulmonary veins, PV, pulmonary veins. He found out that in a group of patients who have what we call paroxysmal atrial fibrillation, now we all know what paroxysmal atrial fibrillation is, the one that happens, comes and go by itself. He found out that 94% of the triggers for the episodes of atrial fibrillation come from the areas of the opening of the pulmonary veins as they connect to the left top chamber. And he proposed we go after that trigger and ablate within the pulmonary vein or outside the pulmonary vein. And that's the basis for targeting the pulmonary vein and trying to isolate those trouble zones from the rest of the top chamber. Also highlights not 100% of the triggers are in the pulmonary veins. Once we isolate the trouble zones, we look for other areas, and if we can identify them, we'll go after them. This is published just last month in the New England Journal of Medicine, again highlighting the progression from paroxysmal atrial fibrillation to persistent atrial fibrillation, the one that will not stop unless you cardiovert the patient. And once it lasts longer than a year, we call it long-standing persistent atrial fibrillation. You can look here, and this is the stack of the muscle fibers in the atria or in the top chambers of the heart. This is the back view of that left top chamber with the 4 main vessels bringing the blood from the lungs to the top chamber of the heart, the pulmonary veins. In case of paroxysmal, we found out that the triggers are at the opening of those veins, again, in that specific study, 94% of the times. And that signal goes around very fast, causing the top chambers to fibrillate. If they go untreated, and if we wait longer and longer, what happens? That top chamber fibrillate often enough, long enough, it dilates, gets bigger, and to dilate, it develops some scar tissue between those muscle fibers. And we just learned and agreed, hopefully, that scar does not conduct electricity. All of a sudden, you have those islands of scar that allows the circuit now to go around the island of scar, wherever it is or may be. And if you wait longer, now you have really a long strip of scar, and every little muscle fiber group have its own multiple circuits and foci that are going around, and this is a representation of what we call multiple foci or multiple circuits or persistent atrial fibrillation. And everything we're trying to do through these webinars, through education, through intervention, is hopefully to catch atrial fibrillation as early as paroxysmal, so we don't progress to the persistent. Why? Well, we'll learn more. This is another representation. This is the back of the heart. The focus is in the left top chamber, as we mentioned. Why? Because most of the triggers, most of the trouble is basically, most of the troubles are coming from the left top chambers. This is a representation of the muscle fibers in the left atrium. You see bundles crossing, and as they come to the veins, those are like vessels, like tubes. They don't have usually muscle fibers, but at the welding point, at the connection point with the top chamber, you see those muscle fibers wrapping around like fingers, holding tight to those vessels. And those areas of connection are usually the trouble zones. And this is a representation of paroxysmal, small, bad zones at the border. You know, border zones, always trouble. You can't build a wall here, unfortunately. Well, we will. Okay, so this is a representation of persistent atrial fibrillation. Those trouble zones, if they are not attended to, they convince other healthy tissue to join and create more bad cells. Now, you have to go, instead of running after 1 or 2 or 3 spots, you have to go after a crowd, and you can understand why it would be hard to catch all of them. So now we understand the difference between paroxysmal and persistent and representation of where those circuits are. We can understand the approach for catheter ablation. So in case of paroxysmal atrial fibrillation, where the troubles are limited to the connection areas between those veins and the atria, we can go and create a fence. Trump would love that. That's building a wall around the opening of the pulmonary veins on the left and another on the right. And you say, why don't we build wall around each vein, only around the vein that's causing the trouble? We started doing that, but we found out when we burn close to the opening of the wall of the vein, that scar can shrink the vein and sometimes can occlude the vein, cause narrowing of the vein and occlusion of the vein. That's number one. Number two, we noticed if we go after only the troubled vein at that point, other veins become a problem later on. And that's where the approach. Once we get in, let's just go after all the 4 veins, because we know more than 90% of the trouble coming from those zones. So let's go and secure them every time we go in. But that's the case in case of paroxysmal atrial fibrillation. What if we have other areas somewhere else popping up? Why? Because we didn't attack those trigger zones early enough, and now we develop other circuits everywhere else. That's where the role of drawing other lines. You see them here? All these kind of lines going after all the trouble areas. And sometimes we have to put dots in so many places to attack also what we call ganglionic plexi, or collection of nerve endings that also play a role in triggering and causing and perpetuating atrial fibrillation. How do we know where to go? Now we understand the target, but how do we know exactly in this specific patient where to go? We have amazing video games. You know, I always tell my staff, we should pay for the fun we have, not have you pay for it. It's like playing a video game. No, but we take it very seriously. So we go inside the left top chamber. We have a catheter that goes around. The catheter has fingers, just like my hand. And we go around and touch the walls of the left top chamber. We go inside the veins with that catheter. Every point, every spot touched by that catheter, we have a software that connect all those dots and create a 3D of the top chamber. This is an actual 3D I created. And this is a 3D by the CT CAT scan we did of the same patient. They are identical, with one difference. This was done a week or two before. This was done during the procedure. Not only this, we have the ability to see all the catheters inside the heart. Look, the tip, this green tip here, this is the tip of my ablation catheter. I have a GPS system with magnets under the patient that allows me, with accuracy to 1 millimeter or less, to localize the tip of my catheter and other catheters I have inside the heart. Now, I have a 3D anatomic reconstruction of the veins and of the atrium. I know exactly where to go with the tip of my catheter, and we'll learn more. So this patient, I thought I'll show you a fresh patient, so without disclosing any private information, so you'll be a little bit excited. This is last week. So I went inside the heart. I touched the different points of the top chamber on the left. These are the veins. You can see them. This is the raw image. And the beautiful thing is, every point I touch, if it has electrical signal, it gives me purple. If it has no electrical signal, it gives me red. Red is dead. Of course, as you go inside the vein, those muscle fibers wrap around the opening of the vein. They don't go in forever. So now I know this is the top chamber. I know the volume of the top chamber. Is it dilated? Is it small? Is it normal? And I see those veins. And we just reviewed. I'm going to go around those veins here and around those veins here with my catheter. And we're going to learn what this catheter is. This catheter is placed in the esophagus, which is the tube that connects the throat with the stomach. So I know exactly what it is to avoid damaging it. This is the same patient, and these are the lesions I placed, one dot at a time. Each dot is about 5 to 6 millimeter in diameter. You can have the overlap of these dots to create full barrier or circle around those veins. How do I know that those dots creating complete transmural, meaning full thickness lesions and creating scar and preventing any electrical circuit or currents from coming out or going in? It's simple. Once I finish the line on both sides, I go in and check for any electrical activity. And like you see here, I could not find any electrical activity here on the left or on the right. So I know my line is complete. My wall does not have any defect that allow anybody to sneak in or out. So now all the triggers that used to happen here and go out to cause trouble are trapped here. Anything that happens in the pulmonary veins will stay in the pulmonary vein going forward. And that's what the map looks like before and after. Again, this is from last week. Now you need to remember, this is actual live case, recording here, the catheter in touch with the left of the top chamber around the left pulmonary veins. This is a different patient. And I can see the sheath, I can see the Castor tip, and actually, we do those procedures with no fluoroscopy at all or minimal fluoroscopy. And that's amazing, the technology we have today that allows us to do that. When we first started, we used to use up to an hour, even more, of X-ray that creates potential hazard to the patient and the staff and the physician. So this is the catheter, the most advanced we have today. This is the Castor tip. But I would like to Bring your attention here. You can see here, you probably can read, it says force in grams. You can see stability. It tells me how stable my catheter is, meaning my hand, and the impedance, and how long I've been applying this catheter. This is the time. We usually apply the catheter between 5 to 20 seconds, depending how much power we're using, how much force we're using. So you can see all these numbers at the tip of this catheter telling me not to push too hard, not to stay too long, and once the lesion is created, I stop all that to minimize the complication, risk, and assure effectiveness. So this is, we finished with the left side. We go to the right and do the same thing, 1 point at a time. And of course, I'm doing this 1 point at a time. And remember, this is a beating heart. And you think that's easy? Try it. No, don't try that at home. So this is the catheter under fluoroscopy, the same catheter. That's how it looks like. Of course, you don't see the heart. And that's the advantage of having a 3D map with the 3D reconstruction I just showed you. That's how we used to operate in the past without guidance of 3D. And this is what it looks like in real life. The heart is beating. You're trying to create contact with inside of the heart, just good enough to create the lesion and not too much to perforate. So it is a challenge. Nonetheless, there is always that possibility of perforation, which we'll talk about in a few slides. This is just to highlight the technology at the tip of that 3.5 millimeter catheter. You can see here on the left, fluid irrigating the tip of the catheter to cool it down a little bit so you don't have heat high enough to create a clot that can cause a stroke. So that's one thing, and you see the holes here. There is 3D location sensors. There is a spring that allows the tip of the catheter to flex a little bit in case you're pushing too hard. There's a sensor for the force, a sensor for the temperature, all that in that little tip of the ablation catheter. The technology has just improved so much. It's been beautiful to take advantage of all that. So we just discussed one patient that came in with paroxysmal atrial fibrillation. We took care of the veins. Unfortunately, we do that. And some of you who may have had atrial fibrillation or know somebody who had it or may have it, let me explain one point. So this is a patient I had paroxysmal atrial fibrillation. We went in, remember, we created the lines here that gave us all this red area with no signals on the left, no signals on the right. He came back later, I think this was about 2 years later, with atrial fibrillation again. So we thought, wow, okay, let's go check the fences we placed around those pulmonary veins and see if they are still good, or if any holes created in the meantime we need to touch up. So I go in and I check those veins, very silent. That means the job we did the first time was really good. But the top chamber created more and more circuits that I had to go after. And look how many dots I had to go and place in order to silence that part of the top chamber, the whole posterior wall of the top chamber, in order to stop atrial fibrillation. Unfortunately, we have things that make us expect something to come back, and other criteria that say, look, the chance of it coming back is less likely. For example, somebody who's young, healthy heart, top chamber is not that dilated, no leaky valve, we catch atrial fibrillation early, highest chance of success rate, maybe 80, 90%. If you have somebody overweight, sleep apnea, high blood pressure, has been in atrial fibrillation for a long time, has been delaying treating it for a year or 2 or 3, even if I start and I put that many lesions, chances are there will be sometime in the future that we have to go back in and touch up. We cannot predict exactly, however, who's going to come back or when. That's why we say we don't know. We'll just have to wait and see. And I have a lot of patients initially did not accept the fact that this doesn't work with high success rate as they would expect or they hear from other kind of rhythm problems. If the rhythm problem you have is one circuit or one spot, as it is the case with all other or most other rhythm problems, we go after the circuit, we create a line of block, we create one dot where that focus is, we're done. A lot of rhythm problems, our success rate close to 100%, and the chance of it coming back less than 5%. Why? Because we go after one spot, one circuit. Here, you're going after a crowd. I tell my patients, each one of us can relate or know somebody who has a stent that's placed in one of their arteries. When we go in and find a blockage in a patient who had a heart attack, we find the blockage, we open it up, we put a stent in. Now, we cannot predict if the same stent is going to come close back down again, or another artery is going to block down the line. We don't know. We can't predict. So if the same patient comes back with chest pain, let's say a year or two later, or 5 years later, or 2 months later, we go in and do the heart cath again and look at the stent we put in the first time, and we find it wide open. We say, wow, we did a good job first time. Nonetheless, now we are dealing with a new plaque that's built up. In the meantime, we have to go after it and open it up again. Once I tell my patients that, they can put things in perspective and accept the fact I'm just showing you. Sometimes, no matter what we do, other circuits keep building up, and we just have to go after them. Now, before we do a lot of lesions in the back wall of the left top chamber or the left atrium, as I told you, the esophagus is very close to that top chamber, and the heat can create a scar and can damage that esophagus and can create connection between the top chamber and the esophagus, and unfortunately that could be life-threatening, and we'll learn about that in the complication portion of this presentation. So sometimes we are limited with how much we can do in this posterior wall, and that's why we have other option, which is the surgical option, what we call convergent procedure. Dr. Lanquist does it for us here, and he's part of our team. And I was just telling him today, it feels so good to be part of a team that we have everything that there is to offer to our patients. So we go in the back of the heart, and with this tool, we place all these lesions, and the esophagus would be in the back side of those lesions instead of being on the receiving end. And by doing that, we avoid damaging the esophagus in case every time we go close to the esophagus, the temperature in the esophagus goes up. And this is an animation of this procedure. Little incision just below the chest. See that? We go in and we put that tube that will lead us to the back of the heart. Let me just go back. And it has like a suction cup along its length here at the end. And once it adheres to the back of that top chamber, we create scar. Look how many lesions at the same time. So we take out this whole back wall of the left top chamber and basically take care of creating a scar that stops all these circuits in those areas from happening. And that procedure usually could be done after we do our ablation the first or second time, if we are finding areas that we cannot safely ablate, or we can do it in combination, meaning we do the ablation procedure surgically, then we put the catheter inside the heart and find the areas that the surgeon could not get to and fill in the gaps. And this is just a good example of what we call the hybrid approach, which we do in some patients. Now, also trying to make you understand the importance of early intervention, I thought this something everyone can relate to. In Florida, humidity, moisture, hurricane, I think every one of us know what mold is. So this is on the left here, you have a door, wooden door with some mold spots, and way more mold spots here. We all agree I don't have to ask you to, to be sure of that. That's going to take less time to clean this door with less likely chance to come back, whatever cleaner you have, than to clean this area. We all agree it's going to take way more time to clean. And you know, no matter how shiny and clean at the end of the cleaning it looks like, you know, this mold somewhere is going to come back. So if you think the same way when it comes to atrial fibrillation, I thought, how to remove AFib from your heart and keep it from coming back? Well, if you think of the little spots on the left as paroxysmal atrial fibrillation and the one on the right as persistent, with the one on the left with little spots of mold and a lot of mold, you can imagine why taking care of paroxysmal atrial fibrillation is much easier on me and much higher success rate for you. And hopefully we don't have to see you back in the lab, versus if you wait too long, it's possible, but now you understand how much longer it's going to take me. And once I come out of the procedure, I tell my patients what I find. If it's only like this, I say, wow, it was so great. I just did the circles. I could not find anything else. Versus, wow, I went in thinking I don't have much. I end up finding so many and I had to do a lot. So there is a good chance something's going to pop up down the line. And we don't know when that's going to happen. And that brings me to one point, which is the blanking period after the ablation procedure. The first 2 to 3 months after the ablation procedure, we call it blanking period, meaning this is the time we allow the heart and the lesions we created to heal. And during that time, as the heart is healing, you can imagine like you have a sunburn, itching, the heart is irritable, it's healing, it's inflamed. It's not unusual to have atrial fibrillation happen. Episodes that happen the first 3 months after the ablation, we don't consider that an indication for failure. Only if it keeps happening beyond 3 months, we say, okay, that's failure. We need to go back in and clean up more. So, how to remove AFib from your heart and keep it from coming back? Make sure you know when it happens. Find a way of checking your pulse. If any of you got one of those Cardia or Apple Watches, or know how to check your pulse by checking your wrist, you have an app on your phone. It doesn't take much to just check your pulse. Make sure it's not irregular, not too fast. Because if you find it, even if you're not feeling much, it doesn't cost much to check that rhythm out and find out if it's atrial fibrillation or not. Other than to start a blood thinner to protect you from stroke, also to get rid of it before it becomes too hard to eliminate. So early diagnosis, early intervention, including ablation, are the key. Now, I'm going to talk about other means of ablation or destroying the tissue, and that is cryo balloon ablation. It's basically creating a scar. Instead of by heating, we create a scar by freezing. This is the balloon. This is the left top chamber. Everybody knows the trouble chamber is the left atrium, the left top chamber. The veins, as they bring the blood to the left top chamber, the area they connect to the chamber are the area of trouble. And we need to isolate those areas. So we put the balloon in, we inflated contact points, then we run liquid nitrogen as it goes from liquid to gas phase. It freezes and drops the temperature as low as -80 degrees Celsius. Once the tissue temperature drops below -40, you really create irreversible damage and you create a scar. Earlier balloons had that freezing or cooling zone limited to only part of this half sphere. And only the contact points, of course, can cause the damage. In this area here, you're not in contact with the tissue, so you don't have damage to the tissue. So you can still have a gap here that needs to be frozen or create a scar for it. Now, this balloon we have today, this whole part, half the sphere, is a freezing zone. No matter where your contact points are, you're going to create damage and create isolation of the veins. And these are pulmonary veins of an animal heart. We inflated the balloon here, PV for pulmonary vein, LA for left atrium. You inflated the balloon here, you inflated here, and it created the pale tissue, and that's the scar we're talking about. How do we know we are occluding the vein, which will tell us that the balloon is in contact with the tissue 360 degrees around that circle? Well, we inflate the balloon, we push it against the opening of the vein, we inject dye, and if we don't see any leak of the dye outside, we know the contact is perfect. And this is one of my patients here. Inflated the balloon, injected the dye, nothing is leaking, I'm in good spot, I start the freezing. Once the balloon is deflated, you can see this is a representation of the lesions we create around the vein. No matter what you're doing, whether it is freezing or ablation, it's the same concept. You go inside through the groin to the heart, you cross from the right top chamber to the left top chamber. You occlude the vein and deliver the freeze in case of the cryo balloon, or you go with the catheter one dot at a time around that vein and create the circle. You might say, wow, this is really good. Why would you use the catheter here if you can use the balloon? Actually, it may take less time to do the balloon, but just remember, the balloon may be a good idea for some patients, but not if you want to go after all these little spots in corners. This is like big brush versus like little tiny brush. You can go after any spot anywhere you want much easier. Regardless, whether you choose chilling or grilling, the effectiveness is comparable, and we have all these tools at our disposal, and sometimes we end up using both. Now, no matter what study you look at, so many studies are available to show that ablation is superior to antiarrhythmic medications, keeping people in rhythm. And this, another study, again, comparing ablation, the top line, staying in rhythm, versus antiarrhythmic medications. Of course, this is not only paroxysmal. Usually, if you have paroxysmal atrial fibrillation, the chance of staying in rhythm is the higher, almost 90 plus, around 90%. As you go to persistent, the success rate with the first ablation tend to go lower. And this is the time we call the blanking period. It's about 3 months, 90 days. We don't look at any recurrence during that time as a sign of failure. This study was just published also last month. I just tried to bring you some fresh studies where they randomized patients with paroxysmal atrial fibrillation to use drugs or to go with the cryo balloon ablation. And they put a loop recorder under the skin to detect any atrial fibrillation. And they followed them for 1 year. And they found that cryoablation maintained people in rhythm significantly higher than those taking medications. This is relying on continuous monitoring of a monitor under the skin 24/7 for the whole year. And even if you have seconds of atrial fibrillation, 30 seconds or more, they consider that a failure. But as far as the patient is concerned, they are concerned with the symptoms. Symptomatic recurrence of atrial fibrillation, when you use the ablation, was only 11% recurrence after 1 year versus 26.2% in the antiarrhythmic group. Complication rate was the same in both groups. So this is a very good, most recent study showing how as safe it is, the ablation procedure, with way more effectiveness maintaining the rhythm. Much larger study, the Cabana Trial, in this case, more than 1,200 patients randomized, whether and also monitored for any recurrence or symptomatic recurrence. Having atrial fibrillation ablation maintained sinus rhythm way more than the drug group. And when it comes to symptomatic recurrence, also ablation group did much better than those who were treated with medications or antiarrhythmic medications. And this slide also highlights the importance of continuing with medications and with anticoagulation even if you think you're staying in rhythm. Many patients say, oh, I know when I'm in atrial fibrillation, whenever I am out of rhythm, I can tell. No worry, I'll take a blood thinner then. Well, no, I will worry, because so many studies with monitors showed that you can have atrial fibrillation without knowing about it. Of course, you can't convince everyone of that. So the easy way out is to tell them, how about when you're asleep? And say, oh, okay, I can't argue there. Well, I know they can have it even while they are awake without knowing about it. Why? Because it could be asymptomatic, as we discussed. It could be shorter in duration, and the patient could be busy and distracted by other daily activities. So if you have indication for blood thinner, continue with it regardless if you think you're staying in rhythm or not, because the indication to continue with the blood thinner or not to continue with it, it's not whether you stay in rhythm or not. It is depending on your CHA2DS2-VASc score. Remember that score that goes from 0 to 9? If you have high blood pressure, diabetes, your age, heart failure, prior history of heart attack, blocked arteries, and so forth. All these trials, and the one largest and longest follow-up is the Cabana Trial. We were hoping to answer some questions regarding mortality and show us some improvement in survival, but actually failed to show significant improvement in survival, but for sure told us that atrial fibrillation ablation does reduce the incidence or the burden of atrial fibrillation when compared to medical therapy, and also reduce the symptoms, improve the quality of care, and reduces hospitalization regarding atrial fibrillation. The one study published in 2018, which we call Castle AF, showed that atrial fibrillation ablation compared to medical therapy can actually reduce death or improve mortality and reduce hospitalization due to heart failure in patients with heart failure. If the patient has heart failure, weak heart, atrial fibrillation ablation tend to reduce hospitalization for atrial fibrillation and improve mortality. So that's one good study to look at. Now, before we get too excited about the procedure, how about the price? What are the complications? Well, let me start by reassuring you the most dreaded complications are stroke, heart attack, and death, less than 1 per 1,000. So relax and pay attention to the following slides. Let me give you an idea what the pericardium is. It's the fibrous, really tough sac in which the heart beats 100,000 times a day and beats nicely, and there's a lubrication, a fluid that goes between the two layers of this sac. Now, I told you, this is the heart, this is the chest CT scan, this is a normal heart, a CT scan, and the pericardium is the sac around this heart. These are the top chambers, the bottom chambers. Of course, they don't look top and bottom here because of the way we cut the slices. This patient had effusion, meaning blood accumulating around the heart within the sac. See how the sac is well demarcated? Blood is not going all over the place. It's staying within the sac. And the sac's so tough. When the blood leaks, what's going to happen? It's going to squeeze the heart and prevent the heart from receiving the blood and pumping it out, so the blood pressure drops. Luckily, this risk is less than 1%. And what do we do if that happens? We stick a needle in that sac, get the blood out, reverse the blood thinner the patient is on, and transfuse blood if we need to. And 99.9% of the times that works. Less than 1 per 1,000 chance we need to open the chest to close that hole. But that's, again, so rare. You just have to hear about it. And anyone we perform ablation on, we tell them all these possible complications. Another possible complication, less than 1%. Let me orient you here. This is the X-ray, chest X-ray. This is your heart, lung on the right, lung on the left. And this is the abdomen here, the liver on the right side, the stomach, some air in it here on the left side. And this dome here, another dome here, this is what we call the diaphragm muscle. This is the muscle that separates the chest from the abdomen. And when you breathe in and out, it moves down to breathe in, expand the lungs, get air in, and moves up when you exhale and get the air out. If you damage that muscle, if that muscle is paralyzed, look what happens to it. It goes up. Now you cannot move the muscle down to open your lungs to get more air, so you get short of breath. Is it possible to damage the nerve that goes to that muscle? Absolutely. Luckily, less than 1% chance. And you can see the difference in height between this muscle here and this muscle here. Here, it goes up and down. In this case, it just stays there. So if we open the chest, the back of the chest, we see one nerve here going down this yellow line to the muscle. That nerve we call the phrenic nerve. This is the nerve that makes this muscle contracts. And the one on the left here make this muscle contracts. Why do we have a chance of damaging this nerve more than this nerve? Because of the proximity of this nerve to where we put our lesions. Let's review. This is the left top chamber. You should be sick and tired of this picture by now. This is the left top chamber. These are the veins bringing the blood to the left top chamber, and this is the area of interest where we put our lesions. Guess what this is? This is the nerve that goes down to this muscle here, the diaphragm, and help us breathe. And if you remember, the lesions we put around those veins, look, I'm getting closer, closer. I'm too close. Of course, we test, we delineate its location, and we try to avoid damaging that nerve. And thank God, in our records, even way less than 1% chance. Luckily, damaging that nerve, even when it happens, it has a high chance of recovery because the damage is indirect. Remember, the heat is coming from inside through the heart muscle to outside. So it's indirect damage, and the nerve tends to correct itself within 6 to 12 months. Now, one of the most dreaded complications, to understand it, let me orient you again. This is a CT scan or MRI. This is the heart. This is the front. This is the back here, the spine. This is the left top chamber, area of interest. And this is the tube that connects the throat here with the stomach down. We call the esophagus. And this is the back of our left atrium. Look at the proximity between the two. We're literally talking a few millimeters away. So now you understand why heating here can get through and through and damage the esophagus and create a fistula. That's not a good thing. Unfortunately, that's life-threatening. Fortunately, that incidence, less than 1 per 1,000. How do we minimize that risk? I'll tell you in a second. But this is also to show the relationship between the left top chamber with the esophagus. When you look at it from the back and you say, wow, well, how close are they? That could be deceiving view. Yeah, it could be. But if you looking from the left and looking from the right, it's like exactly against that wall. So how do we minimize that risk? Few things we do. Number one, we put a tube inside that esophagus so we know where its location. And we try to stay away from it, number one. Number two, that tube has a temperature sensor at the tip. And we move it up and down as we are putting spots. And if the temperature rises, any rise in temperature, we stop what we're doing and we stay away from it. But now you understand why we could be limited, ablating everywhere we want to ablate. The last part here is the vascular axis. We go through the vein or the artery, but most of the time through the vein. And remember that catheter goes inside the heart and the current flowing to outside. And of course, vascular axis complication is the most common. Its incidence has been reported as high as 13%. Everything we do it carefully, and we try to minimize that risk. And we are hoping for 0 complication. And we started looking at every vessel we go into with ultrasound. This is from the internet, so I'm not breaking any HIPAA here. And under ultrasound, we put our needle and enter the vessel of interest. And as a result of my partners and I implementing this new way, we've been using it for a few years. Last year, we tracked our complication. We had more than 2,000 sticks. Guess what was our complication rate? 0. 4 operators, 3 labs, 2 hospitals. And actually, we're submitting an abstract bragging about it. So when do we need catheter ablation? We do it because it reduces the symptoms, improve the quality of life, much better than drugs do, and is safe and more effective as a first line of therapy. And you don't have to use drugs first before trying ablation. It's an acceptable first step based on the studies I just mentioned, and it helps improve the patient's symptoms, especially if they cannot take the medication or the medications are ineffective. So in summary, if you have atrial fibrillation, number one main concern, make sure you take anticoagulation to reduce your risk of stroke. If you're symptomatic, we need to get you back in rhythm. The two options, medications or ablation. I hope I made the case for ablation way better. Sooner or later, you're going to end up there. So it's only buying time to try the medication, and that's reasonable to do, depending on what you want. If the patient is asymptomatic, it's reasonable to live with atrial fibrillation, depending on the patient, the age, the comorbidities. And that's the end of it. And that's the end of the webinar, and I think we're opening it up for questions.